This is Dr. Jill Alldredge. She is an assistant professor of gynecologic oncology here at the University of Colorado, and she is going to talk to us about cancer risk reduction in the setting of gynecologic cancers.
Thank you. Hi, thank you so much for having me. Here we go. All right. So outside of advising AstraZeneca on sort of what might be the future directions in ovarian cancer, I have no disclosures. So some of our goals for today, we're going to talk about just basics of endometrial cancer, who's at risk, what are the things that we can possibly change about our risk, and then the incidence of uterine cancer overall. We'll also talk about some differences in uterine cancer and ovarian cancer risks based on Lynch variant. And then we'll also talk about cancer screening options, some risk reduction strategies. I will briefly talk about hormone replacement, only because that's a very common question that I address for patients. And then I'll introduce pre-implantation genetic testing, which Dr. Ruecka will go over later this afternoon in more detail. So just to get started, endometrial cancer is an enormous part of my practice, unfortunately. What we know is that the incidence of I don't know how to use the, there we go. What we know is that the incidence of uterine cancer is one of the few that's rising in the country over time. We would really like to see the new cases of uterine cancer going down, not up. And we do know that within that also, we have racial and ethnic disparities, that this is disproportionately affecting women of color. All of this is unacceptable. And so we do have to look into what are the risk factors that put people at risk of these cancers and how can we modify those risks. So we tend to think of uterine cancer, just to do a little review here, in two different boats. There are low risk uterine cancers, ones that move slowly. This takes many, many years, if not decades, for these to develop through a pre-cancer mechanism and all the way to cancer. This can be an obesity-driven mechanism, which is probably why we have this increased rise right here. But these can also be driven by hormone replacement. So women who have their uterus in place and only take estrogen replacement for hormones and aren't protecting the uterus with progesterone, not having pregnancies, using tamoxifen, all of those things can increase the risk of these low-grade uterine cancers. We also know that there are high-grade uterine cancers. So these are going to move a lot more quickly, be a lot more aggressive. We do know that race is a part of this. Tobacco use can impact this, and then tamoxifen as well. Most Lynch syndrome cancers are going to be in this low risk group. So if we take a look, the population risk of endometrial cancer, so if we just look at the entire population of the US, the risk of developing uterine cancer within their lifetime is 3%, and the risk of developing ovarian cancer is about 1%. So low risks overall, and certainly that is different in our Lynch syndrome patients. That depending on the different variant of mutation, those risks are quite different. You can see that for women who have MLH1 or MSH2 cancers, that risk can be quite high, in the 20 to 60% range. And for those who have a PMS2 mutation, for example, it can be as low as 15%. So those are going to be different risks based on different variants. And within the ovarian cancer risk group, MSH6 and PMS2 mutations look pretty similar to that baseline ovarian cancer risk. Whereas MLH1 and MSH2 are going to have quite a bit higher risk, up to 10 to 40%. So when we're talking about our risk reduction options, we do have to think of it on a variant-specific basis. And what we know, and I won't make you guys memorize all these things because we'll go over these lots and lots of times here on the right side. But just again, we have different risks within each of these different subtypes. The NCCN, which is our body that gives us these recommendations on a national basis, does recommend that for uterine cancer, this is going to be pretty standard across the board for each of these different variants. Symptom awareness is key. Consider hysterectomy, and we'll talk about what that means. And then considering endometrial sampling every 1 to 2 years, beginning at age 30 to 35 or 10 years before the earliest uterine cancer diagnosis in the family. So again, considering family history in our decision-making. For ovarian cancer, this gets even more complex. That really symptom awareness is key. And then we can talk about some potential hormone manipulation or surgery. In the context of MLH1, we can consider removing the tubes and ovaries. And we'll dive into that again here in a moment. MSH2 and EPCAM are going to be very similar guideline recommendations. For MSH6, I do want to point out that the only difference here is that risk of ovarian cancer is quite a bit lower in this cohort. And so there's insufficient evidence for the NCCN to support removing tubes and ovaries. PMS2 is in that same boat. So let's dive into that just a little bit more. So symptom awareness is tricky because unfortunately the symptoms of ovarian cancer particularly, but also of uterine cancer can be really vague. They can oftentimes mimic irritable bowel syndrome or menopause and so get ignored for quite some time. So for uterine cancer, I think it's really important to know that before menopause, bleeding that is not your normal should be a red flag. That can be bleeding that's heavier than your usual, bleeding that's happening in between periods, bleeding with intercourse. After menopause, no bleeding is acceptable, right? Even a drop of blood after menopause, we should be ruling out uterine cancer. So we just need to have very different thresholds for those two different populations about what qualifies as abnormal bleeding. But I've cared for women who are in their 20s who have uterine cancer. And so certainly it's not that you have to only have bleeding after menopause to fall into this criteria. It can happen with just periods are different. If any kind of discomfort or pain with intercourse starts to raise some red flags, or changes in vaginal discharge can also raise those red flags. For ovarian cancer, we often use this mnemonic BEAT to help us remember these symptoms because, again, they're really vague. And we're looking for things like bloating, eating issues like getting full really quickly, having abdominal discomfort, or troubles with bowels, particularly bladder issues, a little bit less specific. Now, all of these things we're all going to have, right? These are just normal parts of life. But if any of these symptoms were sticking around for more than 2 weeks, then we need to start worrying about those. So please bring those to your doctor's attention if you're having any of the symptoms on this list. As far as ways that we can approach screening in endometrial cancer, I think that it's important to zoom out just a little bit, that 85% of uterine cancers that we diagnose are early stage. So trying to do an intervention that proves that we save lives or that we let women live longer by doing that screening test are going to be really difficult because those uterine cancers are usually low risk, early stage, curable with our interventions much of the time. Proving that something really moves the needle on survival is difficult to do. And so I think we have to first and foremost recognize that we don't have a screening test that changes mortality, right? We don't move the needle on how women survive, but nonetheless, our governing body of OBGYNs and the NCCN support that we do screening nonetheless, because these are really low risk interventions, low risk screenings that have high bang for their buck, right? These are really high yield. Those 3 different things that we can do to screen for endometrial cancer outside of symptom awareness can be using ultrasound. This really needs to be a transvaginal ultrasound, not an abdominal ultrasound. And you can imagine that in women who are before menopause, where the lining of the uterus is changing day by day, this can be really difficult to interpret, right? When the lining of the uterus is thick and we're before menopause, what does that mean? So it's not a good test in women who are before the age of menopause. After menopause, it can be a more sensitive test. We can use it, but superior to that is endometrial biopsy. And I don't know that this picture gives you a good visual of this. I should have taken a page out of Dr. Patel's book and really shown you some anatomy pictures here. But endometrial biopsy is where we actually introduce this tiny suction tube. I would say it's 0.5 centimeter in width. And we introduce that into the uterus in clinic. So this is just something you do during a pelvic exam in the clinic space, not under anesthesia. And we basically just suction cells out of the lining of the uterus. That can be a very sensitive and very specific test. We have tissue under the microscope to tell us about normal, precancer, or cancer in the uterus. And that is far superior to ultrasound. Sort of the most definitive test is called hysteroscopy and dilation and curettage. Now, this requires putting a camera inside of the uterus and then scraping out the uterus with a sharp instrument. So you can imagine that's going to be significantly more uncomfortable for patients. We have higher risks of that procedure. Often we have to do this in a procedure center or in an operating room. And so that difference of sensitivity between endometrial biopsy and hysteroscopy DNC is not enough to put all women through this procedure. So really endometrial biopsy is the standard of care in this space. There are several screening tests that are under investigation at this time because we think we can do better than what we're currently doing. It's important to know that Pap smears are not intended to pick up uterine cancer or ovarian cancer. Pap smears are there to pick up cervical precancer or cancer. And so we are developing a gene panel that can pick up the same secretions that a Pap smear might pick up to look for uterine cancer signatures. So that's intriguing. That's not currently the intention of the Pap smear. This is a new development called Pap-Seq. That's a gene test. They can also use a tampon test to pick up secretions in the vagina and do genetic testing on that as well, or using estrogen metabolites in the urine. So lots of things under investigation to either replace or augment biopsy of the uterus. When we're thinking about different ways to reduce the risk of uterine cancer, we'll start with hormone manipulation. The other name for this is chemoprophylaxis. So you may see those used interchangeably. And basically what we're doing here is we're telling the inside of the uterus to quiet down. And that can be done through the use of birth control pills or OCPs, injected hormones or implants with progestin hormones. When we're using those, we can reduce the risk of uterine cancer by 50 to 70%, or of ovarian cancer by 30 to 50%. So we're sort of killing two birds with one stone with some of this chemoprophylaxis. Progestin IUDs are actually one of the treatments for uterine cancer for women who can't have a surgery. And so we've mostly studied these in the general population. Again, there are smaller studies of Lynch syndrome specific risk reduction, but that we can reduce the risk of uterine cancer by about 80% using an intrauterine device. So if a woman's fertility goals are not yet completed, this is a fantastic option that can reduce the risk until those goals are achieved. We also know, mechanistically, how does this work is a little tricky, but we also know that intrauterine devices can reduce the risk of ovarian cancer as well. So again, really wonderful tools in the toolbox. Intrauterine devices aren't releasing enough systemic hormone to have any additional increased risk, like breast cancer risk or blood clot risk, the way that birth control pills may. So this is worth discussing with your doctor. We also know that the benefit of these continues to last even after that intervention is done. So even after the IUD is out or the birth control pills are stopped, that benefit keeps on going. For the most definitive risk reduction for uterine cancer, we talk about hysterectomy. And there was a big study published in the New England Journal of Medicine in 2006. And this is really the cornerstone for our evidence in this space. What they did is they took 300 women with Lynch syndrome and matched them with 300 women without. And they did surgery with hysterectomy, plus or minus removing the tubes and ovaries. And they saw that in women who didn't have surgery, 33% got uterine cancer and 5% got ovarian cancer. And in the women who did get surgery, 0% got cancer. I mean, that's pretty lovely evidence, right? And we followed those patients for a long duration because initially you have to think, well, did we just look really early and we caught these benefits? But this duration was actually followed out for almost 10 to 11 years. So we see that even over time that we can prevent cancers by removing these things. I do want to point out a really common point of confusion. What does a total hysterectomy mean? I can't tell you how many folks I meet who don't really know what was done, right? What does a total hysterectomy mean to a patient versus a doctor? So I just want to clarify that total hysterectomy means removing the uterus and the cervix. Anything past that, the tubes and ovaries, that's not part of the terminology for total hysterectomy. So it's worth clarifying with your provider, what hysterectomy did I have or will I have? What exactly does that mean? Certainly we can remove the uterus and the cervix along with the tubes, which we'll talk about in a second, or with the tubes and the ovaries. I do just want to point out a small caveat here. We haven't talked about risk-reducing surgery for colon cancer yet this morning in a lot of detail, but removing the colon or colectomy is something that we can consider for reduction of risk for colon cancer. And we're in the same space to remove the uterus, right? Removing the colon, removing the uterus, we're in the same zone within the belly space. And so certainly we can team up to do these things together to try to minimize trips to the operating room and minimize risk for folks. We don't have data on this. No one has done a study to look at, are patients happier? Do we have more complications? Any of those things, no one's ever done that study. I wish I had a fellow here and I could tell them to get on that right now. But we don't have this data yet. Certainly we do this in clinical practice and we have not seen any concerns about safety or feasibility. So I strongly encourage you to talk to your surgical team about this. Why not get this all done at once? Whether that's with a bigger belly incision or a minimally invasive procedure like a robotic surgery or laparoscopic surgery, we can do it. All right, we're going to shift gears a little bit over to ovarian cancer. So what we know for ovarian cancer is that no matter what we have tried so far, we have yet to show that any screening test helps people get diagnoses of ovarian cancer sooner or to live longer when they are diagnosed. So whether it's in the general population or even in like the BRCA1 or 2 mutation where they have a very high risk of ovarian cancer, we don't have a screening test. Pap smears do not detect this. We are just not very good at screening for this cancer yet. And so I just want to point out that things like ultrasound, looking at the ovaries, blood tests that are out there like CA125 blood tests, those may be things that you hear about. We do not have good enough data to say that we can screen patients with these things and actually do them any benefit. So we don't have a screening test for ovarian cancer. Some of this, additionally within the Lynch syndrome population, is that the cancers that do tend to happen in the ovary are different than the cancers that happen in the general population or in BRCA carriers. They tend to be more of a flavor of ovarian cancer called endometrioid cancer. Those behave completely differently. And so a lot of these recommendations about ovarian cancer, we're extrapolating from those other populations. We're saying those things probably apply to Lynch syndrome. But the reality is we don't have that data in Lynch specifically, and we don't have a good screening test for ovarian cancer. We can talk a little bit about the birth control pills that we talked about in that last slide, or intrauterine devices, that those are things that we can reduce uterine cancer risk and ovarian cancer risk at the same time. So those certainly have added benefits. But what do we do with the tubes and ovaries for women who do have Lynch syndrome? And I think that I'll just give you the caveat that what we call ovarian cancer is probably not ovarian cancer most of the time. Probably fallopian tube cancer, the vast majority of cases, and rarely does it actually start at the ovary. So when we talk about opportunities to reduce the risk of ovarian cancer, what we can actually do is remove the tubes. And removing the tubes alone can reduce the risk of ovarian cancer 65% of the time. So even just taking out the tubes along with the uterus goes a long way towards reducing this risk of ovarian cancer. That can either be done at the time of hysterectomy or at the time of permanent sterilization, and doesn't actually change how that surgery goes. Removing the ovaries themselves, we can consider in women who have MLH1 or MSH2 mutations. Like we saw, perhaps there's a lower risk of ovarian cancer if we do remove them. We have to weigh that against potential benefits of hormone replacement therapy versus risks of not being able to get hormone replacement therapy and having increased heart disease or bone thinning and fractures. There are consequences to taking out ovaries early, and we have to weigh that against the benefits. So these are conversations worth discussing with your surgeon. There are a lot of different risk reduction strategies on the horizon, as Dr. Patel alluded to, vaccines that are really exciting, anti-inflammatory medicines, whether it's aspirin or naproxen, immunotherapies, and all of these should also translate into the uterine cancer space. So we have our eyes on those for the future. And for those who just want a kind of consensus summary of our risk reduction and screening options, I have our NCCN guidelines summarized here for you. So for both endometrial cancer and ovarian cancer, your screening and risk reduction guidelines are all summarized here. Just briefly, I want to touch on hormone replacement therapy. This can be a really confusing topic for folks. So as a general rule, if the uterus is in, you have to protect it from estrogen. We can cause uterine cancer by giving people estrogen alone. So we have to be on both estrogen and progesterone to prevent uterine cancer if we're going to use hormone replacement when the uterus is in the body. If the uterus is out, fantastic. We can just use estrogen all by itself. And we do have data that says that use of hormone replacement therapy with estrogen in it can decrease the risk of colon cancer as well. So lots of food for thought. Dr. Roca later is going to talk about pre-implantation genetic testing. So I will not steal her thunder, but as an OBGYN, it's hard for me to not talk about some potential ways to impact future fertility. In the interest of time, I will not dive into this. Here are all the things we talked about today. I have to shuttle my children around this afternoon, so I'm so sorry to not be available later on in the day, but if you do have questions, please do let me know. I'm happy to see you in our GYN oncology clinic to talk about these things in more detail or to be available for questions. Thanks.